Well, so I'd like to welcome our second panel, and we'll talk about some oral medicine integration and some real actions. And the people on this panel have been out there testing the waters with very innovative and disruptive models, which I love. Okay, so I'm going to take a moment. If you want to go ahead and introduce yourself, Azim. Yeah, who you are, where you're from, and what you do.
How are you? I'm Azim Malik. I'm the Vice President of Enterprise Strategic Partnerships at CareQuest Institute. We are a nonprofit that advocates for the improvement of oral health access and quality and equity for all. We're about 1.5 miles up the road here in Charlestown, whereas Bob, that took me about 35 minutes this morning to do that 1.5 miles.
Ed.
Good morning, everybody. I'm Ed Shellard. I'm President, CEO, and Chairman of the Board of United Concordia. We're a non-for-profit insurance company, and we're part of Highmark Blue Cross Blue Shield. Our claim to fame for those Bills fans were Highmark Stadium. That's part of us.
Did the Bills lose the other?
Hey. Sorry. Because they had those new jerseys. We got to get rid of those new jerseys.
I am Steve Thorne, the CEO founder of PDS Health.
Great. And where are you based?
We are based in Henderson, Nevada now.
Great. Thank
But
you.
we're all over the country. And we used to be Pacific Dental Services, so now PDS Health.
Yep. Great. And what's this guy's name?
I'm based here, and thank you again for coming.
Hi, good morning. I'm David Kochman. I'm the Chief Corporate Affairs Officer for Henry Schein. So we're a global health solutions company. We service the subacute market, medical and dental, primary care, everything from products, equipment, technology, services. Thanks for hosting this. Thanks for moderating. And Brett, I'm not sure if you got appropriate applause, but I know you're giving up your presidency in a week. You've done a phenomenal job. May I just ask a round of applause?
Yeah.
Been quite a year. It's been quite a year. This political environment's been, but they say the best sailors don't get their way by staying in port, right? And so I've been out there fighting, navigating through these storms for the profession, and it's been amazing year for me. So thank you. So I talked about dentistry as an essential, critical part of essential health. And so I'd love to hear from your viewpoints, your views on essentialism. Do you feel it's essential or not? And why? I'll start with you, Azim.
Sure. I mean, we absolutely feel it's essential. It's a core value of what we do to ensure that everyone has access to quality oral health care. And in the past 6 months or so, we have taken on this initial initiative of linking that with this medical dental integration work. We see that as incredibly important, as there are 27 million Americans that see a dentist every year without seeing their physician. So it should be a part of their overall healthcare journey, and how we can link that, and many of the examples that you and the previous panel have given are what we're out there trying to speak about more and make those collaboration points and connections in the industry.
Great. Ed?
Yeah, I think we're all in violent agreement, right? It's important. It should be essential health benefits. I'm not going to pontificate about why. I think we've been talking about it for years, but it is certainly important, and it's enough already.
Okay. We'll come back to some actions that we're doing in our own little world about that.
Yeah.
Go ahead. Steve?
I don't think any serious clinician doubts the oral systemic link in the entire world. It's that powerful. Every day, my phone blows up with some new study, some research about what's going on in our mouth and how it affects our bodies. And we got to get moving.
Well, as a scientist, we can actually providing the solid evidence the connection is there. And I just look forward to work with all my colleagues at the different segment of the dentistry, how to make this a reality. I think oral, it's very interesting. The first concept of oral systemic connection was happened as one article at Forsyth published in 1926. And so beating the drum is easy. Really, the question is about how we get in the real action. I look forward to the discussion.
Yeah, I think that's right, because it's a multi-stakeholder problem. It's a complex problem to solve. So I think everyone's going to agree that it's essential, but we can't solve it ourselves as well. How do we get engagement from the public, apart from doing a Got Milk campaign, right? How do you get engagement from the public so everyone agrees, stacks hands, and we need to solve this, and we start working together to do it?
So interestingly enough, and this will kind of go on Steve, what you said, that any practitioner who is anything understands that it's essential. I give a version of this presentation across the country. I think I visited 30 dental schools this year, and I gave it to them. The dental students and the faculty, they love it. But I've given it to several dental study clubs, practicing dentists, and people want to throw tomatoes at me, tell me I'm crazy. Why is that? Because it challenges their norm. And whenever a disruptor enters into the market, and Steve, you've probably taken your share of tomatoes too. Whenever a disruptor enters in the market, the status quo will dig in and try and prevent that disruption until you break through. So Steve, you want to talk about some of the challenges you faced with your business model?
Well, it was you sort of opened it up at the beginning. We have a failed reimbursement model, right? There's no such thing as dental insurance anymore, right? We have dental plans, basically a $1,500 coupon. I started in this profession in 1989. We have plans that are the same. Same.
Yeah.
It's insane. And so I feel your pain when you're talking to these associations, because they get paid, they make their living to fix something that's broken. They don't get paid for that prevention. It's starting to change, and hats off to organizations like Delta Dental in Massachusetts that's starting to pay for saliva science, saliva diagnostics, referrals for that. It's starting to change, but yeah, it's very hard. We started on this journey in 2015. We now have about 20 integrated practices. And I'll tell you what, the integrated practices, all of our integrated practices are on our top 50 of our 1,100 practices.
Top 50 in producing?
Just overall revenue and profits,
Okay.
profitability. And Google, patients love it. Patients love it. They get it. But I think the fundamental, back to answer your question, I think we do need to evolve the reimbursement system. And I have a lot of empathy for Ed and others and what they're trying, because they have to convince the payers then that this makes sense. So we have to prove out that we can benefit diabetic patients. We have to prove out that we can benefit hypertension patients. We have to prove these things out. Cardiovascular disease, you brought that up. We have to prove that out so payers are willing to pay for that. Otherwise, we're going to be having this conversation, I think, 10 years from now, 20 years from now.
Right. So that's a great segue for Ed. What are you up to?
This is always how it goes, right? Brett stirs it up, Steve tees it up, and then I get it next, right? So I completely agree. I agree with Steve. So record that. That it's broken, right? It is truly broken. And I think, you quoted it, Brett, earlier. It's actually 4.4% of all patients that have insurance never reach their ELA max.
I was giving you-
4.4.
I was giving you the benefit of the doubt.
Yeah, you got it to 6, but it's actually lower, right? And so I agree with Steve. It's broken. It's been the same way forever. I think what I would suggest is that we consider, and we talked about this earlier, and the panel before talked about education. Truly, if from an insurance perspective, and I didn't appreciate this, right? I mean, my career has been I practiced dentistry, and I basically ran, different companies within dental and a lot of R&D background. I didn't even appreciate it until I came to the insurance sector, is that the education has to happen at the employer level. It has to happen with the company CFOs. It has to happen with the company HR administrators. It has to happen with the producer and broker communities that are selling these products to employer groups. We all know right now, on average, healthcare premium costs are going up somewhere between 12 and 30% a year. And my biggest concern, if we can't educate the employers on the importance of dental health, is that those employers are going to say, I have a defined benefit package dollar amount per year to cover my employees. And because healthcare premium costs are going up so high, I'm going to drop vision. I'm going to drop dental. I'm not going to even cover them. So we've got even a bigger issue than worrying about what is the yearly max, in that some employers may go, I don't have the money because the healthcare premiums are going up so quickly. We have to get to the people that have the most weight with the patients and who can control the behavior of the patients. Control is a strong word, but encourage or strongly encourage those patients to go to the dentist, right? And that's the employer. If you think about your own personal experience and how, and I know it from my experiences, I'm covered under Blue Cross Blue Shield plan, the number of hoops I jump through every year, smoking cessation, diet, health, other questions, going to the dentist, going to your eyes checked. I have to jump through those hoops, which are important and the rightfully so. But I do that at the behest of my employer. We need to type this dialogue that we all violently agree. We've been talking about this for years, and Steve and I talked about this in the beginning of the year at Pebble Beach.
We talked?
We kind of yelled, but then we talked.
Yeah.
Do I have to separate you two?
The funny thing is, we've known each other for decades.
But let's be real. The real thing here is we need you.
Yeah.
We need Delta Dental of California. We need you guys. This industry, our profession, would be half or less if we didn't have you, right? But, and I'm just going to call it out again.
Sure.
You guys aren't doing it. You're not putting the data together and selling it to the employers.
I would respectfully disagree.
Okay.
That we did I'll look to my UCD folks. We did work, 15 years ago, 20 years ago on this whole very topic. We've been doing it. We violently agree. We need to continue to do more. I'm not going to disagree with that. But who owns the closest relationship to the patients? It's the employer. We need to exert their influence on the importance of oral health with employees. And we don't talk about that enough. We talk about educating physicians. We talk about changing the medical educational system so that they can actually spell teeth, right? I mean, there's a whole plethora of discussions around that, but nobody today, up until now, has said we need to educate the people that have the most influence over their employees, and that's the employer groups.
Okay. When, I practice in this fee for service model, and my patients, 95% of them had benefits, and Steve is right. Benefits drive people to the dentist. May not be comprehensive, but if they feel they have insurance, they can go. I remember sitting front row at a Denver Nuggets game, and Delta Dental's name was all over the arena. And I was sitting next to some guy I didn't know, and I said, "Hey, what's this Delta Dental thing?" He didn't know who I was, and I didn't know who he was. He's like, "Oh, they're amazing. I didn't have dental insurance for like 5 years, and now I'm going because I got Delta Dental insurance." This guy's sitting front row, courtside on a Nuggets game, paying $1,000, $1,500 a ticket. Okay, it's about value, but the perceived value of insurance that can drive us to the dentist is important, and that's how we go. Absolutely, but the benefit plan, as we've said, it has not met up with the needs of the profession. It worked for us for a long time, and it worked really well, but it's not working anymore, and we all know that.
We're here with the best scientist in the world. Okay, he knows this stuff. You know this stuff cold. We now have the data. I wanted to share some of the data because most of you know we moved to Epic. So now, because of Epic, we get incredible data. So
not everyone in the room knows what Epic is, so please.
okay, Epic is it's much more than an EHR, but it's a
Electronic health record
system. Electronic health record. Sorry, using slang. So Epic is, there's, I think, over 300 million people in the United States on Epic, so they get incredible data. A couple of years ago, they created this data pool called Cosmos. It's the best data pool, I think, on the planet. 15 billion records in there. So I had my team go in this week to prepare for this. Just looking at patients, we've only been on it a couple of years. So just looking at a population pool of patients that have had their A1C tests. We do a lot of A1C testing in the offices. A1C tests. So we looked at pre-diabetic and diabetic patients. And then we can compare that to their decrease with number of cleanings and decrease in A1C. Wouldn't surprise you, highly correlated to decrease. Then I asked, what is the correlation to emergency department visits and hospital visits? Because of Cosmos, we can get that data now. It's incredible, incredible. So these patients, these diabetic patients, in a couple years, a 17% decrease in hospitalizations.
Mhm.
Highmark should be all over that,
Yeah.
selling that to employers.
Yeah.
We have the data. There's so many studies just out there, right? But now there's real data, real patients. We can name those patients that had that decrease. And we have to, as an industry, I am so passionate about this, right? We have to be able to sell that. If we're going to make headway here, we have to sell that thesis. We have to sell the savings, meaning the carriers out there with the relationships and the brokers. You have to sell that savings so they'll contribute it to their overall benefit package. Okay,
So-
I mean it's insane how good it is.
You know, as this year, I've been quite an advocate talking to legislators and trying to raise the oral health literacy. We talk about oral health literacy. That doesn't just go to the patient, the public. It's got to go to the profession. It's got to go to the medical profession as a whole.
Mhm.
It's got to go to the the educators. It's everything about staking our claim and where medicine and dentistry can really help each other. We know that every dollar that we invest in periodontal care in a brittle diabetic will save $4 on the medical side. We know that, but yet medical benefits don't recognize that. I think the biggest driver of this will be public because it benefits the most people. David had a different take on that when we talked the other day. Biggest driver. So he's talking.
I think what I was saying is that it's not only the profession. We do have to look out there. We have to consider that the public and the patients have a stake in this. We can only do so much to push this. The way I'd say we view this is that there's really 4 journeys that are each independent but inextricably intertwined. We need first state licensing because this is state to state. If the state licensing boards aren't going to let the physicians and dentists do the work themselves, we're not going to be able to move anywhere.
That's true.
Second, we need the products to work, right? We need those products to go back and forth. And that's a lot of what you're going to see out here. This is point of care testing. This is EMR integration, which can happen in a number of different ways, right? Then we need reimbursement. And I'll give you a comment on that because I do think that can speak to the incentive structure. And then fourth, it's the behavior change, right? We are teaching students right now in siloed systems. In some schools, there is a little bit of collaboration there. But if students are growing up thinking myopically that I just focus on my own lane, how do we expect people to practice and think broadly? But going back to, I'd say, on the reimbursement piece, and I think it makes both Steve's and Ed's point, right? The incentive structures need to be aligned in the right way. And employers, I do think, self-insured employers like Shine, we have 25,000 Team Shine members, right? Employers uniquely have the ability to incent their employees to behave in a certain way, to comply in a certain way. And on top of that, it's a recruitment and retention strategy, right? I want to cover more prevention and wellness because I know longitudinally, I'm going to save those costs, those disease states from manifesting into acute conditions. Beyond that, though, I can sell that to employees that, hey, we expect our employees to be with us for a long period of time. So I'm going to invest in your health. But there has to be a concomitant part and acceptance. The profession, the ADA can wave its flag and yell, and you can give the most persuasive speech. But ultimately, if people don't care about their own health and engaging in this way, then we're missing a gap. And the final piece I'd say is that I think we have a manifest opportunity right at this moment, given so much of what's going on, the additional data points we have, people's awareness and perception about what is going on with their own health. They want to understand that. And then the new tools and technologies, those really aren't an inhibitor anymore to getting the data points we need for people to accessing that data and to understand it.
Right. And Hazim, how is CareQuest investing in this space?
Yeah, I mean, it's been really interesting to hear all of these comments here because that's what we've been finding having these discussions out in the market. So, I'm probably the newbie on the panel here in terms of oral health. I've been in value-based care strategy the last 8 or 9 years. And the common things I heard my first few months were, we've been talking about this for a while. We've been doing this for a while. We need to make better points and tell better stories with the data. How do we connect that data? There's no connectivity. And so what we've been trying to do is now convene those partners, build those collaborations with the medical side, bringing both the dental and the medical side to the table. What's been really interesting for me is on the medical side, the desire has been there. We've participated with the Primary Care Collaborative. We've joined the Interoperability Alliance. We continue to hear from the medical side that they see the value, they do understand the science behind it, but they struggle with the how. They don't know where to begin, they don't know where to start, they don't know where to plug in. And so what we are trying to do is find those tests of change, where as we build towards these bigger long-term wins that we're talking about here, whether it be EMR interoperability, payment reform, we have to make a case for the value behind that. And so, whether it is financial, whether it's through quality outcomes, we are uniquely situated to be able to bring the right partners to the table to have those discussions, to sort of be that central point and be that link there. And so, it's something I've been really excited about since joining here, and I'm really excited to hear these types of discussions progress.
To validate what you're saying, we'll see tens of thousands of patients on the medical side this year.
Yeah.
So the physician side and nurse practitioner side are far better at referring over to the dentist than the dentists are to the physician side. 45%. We train them how to do a proper visual oral exam. We train them how to talk about oral health. 45% of patients are referred over. And those patients that get in the integrated practices right now are showing up 6.7 times a year. Think about that. We get 6.7 opportunities to invest in their overall health. It's working.
Yeah.
You just got to make it happen. And in the VBC area, especially with value-based care area, I'm using vernacular again, they get excited about it. And we can make a little bit of money on it. Now, we aren't yet. We're losing money on our medical business, but we're getting close. And I think with maybe some help from you, maybe we can finally turn a profit.
When?
So first of all, see, Dr. Crowley may be happy I'm putting you on the panel 1 instead of panel 2. Maybe you're so itching wanted to join the discussion. I do want to say is I believe in technology. Yes, the things haven't changed. It's always the same amount of the money and the same plan. And as the whole science is evolving, we haven't taken a full advantage of that. I do believe that $1,800 is not a lot as a coupon system, but if we use the money wisely, and thanks for all those new technology is here, most of the dental disease are preventable. When you look at the tooth decay, periodontal disease, they're all bacterial infection. And most of the medical microbial infection is almost non-existing anymore. And I think once we put in the technology right, and that $1,800, it can go a long way. And the thing is, I think, how leverage the technology, integrating them, and enhance the preventive dentistry, which is dentistry is very proud of it, because most of the payer, even though we're beating them up, but they are actually 100% covered on prevention. The only thing is those preventive procedures not working. And if we can getting some of the better technology to it, and that might be the way to truly change the dentistry.
David, and then Azim. You look like you wanted to say something.
Yeah, I totally agree, but it's an and, which is just having great technology alone, I don't think works. You need the technology adoption. I mean, you look at almost technology adoption of anything, right? You get people to try to change their behaviors. There's a resistance there. So we need to, and I challenge the ADA and other platforms to do this. We need to help educate the public about how these technologies are valuable to people's lives, not just showing the clinical and scientific efficacy. That's great. Unfortunately, I don't think a lot of people are persuaded by that. It's meeting them where they are, helping them to understand how this will actually beneficially improve their lives, why they should care about this over driving their kids to soccer practice or paying their mortgage. So those two parts of connecting the technology to where the public is at and bringing them along where we want to go is a key element.
Great. Azim?
So we just spent the last 2 days in Chicago with our CareQuest team and our CareQuest Innovation Partners team, speaking about this. We had lots of startups, accelerator programs that were bringing these technological advancements and new ideas to the table, both that built connectivity from the oral health side to the medical side, but also personal technology that would do things like in-home saliva testing and being able to provide the information that we talked about earlier that we all get from our Apple Watches and other things, so that the patients could also be a part of that conversation a little bit more and take some more ownership of being able to bring these things forward. But to your point, I think it continues to go in a circle there about how that actually comes back to either benefit change, clinical program change, and sort of what's going to be the driver for that finally gets us
Right.
beyond that hump of just continuing to have these conversations.
Right.
Yeah.
We talk about plans on the preventive side. I'm going to disagree with you here. It's true, easy to submit a claim for a prophylaxis, get paid. All of you that are practicing, how hard is it to get paid for SRPs? It's a pain in the ass, put it bluntly. They get denied like crazy. 80% of our fights with carriers, our argument or debates over a claim, over 80%, I think it's 85%, are about SRPs. Here we're talking about periodontal disease and prevention. 70%, the latest CDC study, I think it was 2013. We asked them to update that, right? Because it's really old. What is that? 12 years old now. The latest was 70% of seniors have periodontal disease, yet they get denied like crazy. And it's a constant fight because, I don't know, they're not showing enough bone loss, not enough, bleeding points, not enough whatever. It's like, we have the science, right, to test. It should be the saliva test, what you put up there earlier. Saliva test, they have perio, bam, it's paid,
Right.
right? Because what that does, it creates this distrust with the patient, creates conflict in the office, it creates stress, and it creates, I know for your companies and our companies, how many people we each employ to fight those claims and argue. And I'm not trying to, it can be antagonistic sometimes too. It can be a pain. And it's a simple one that we can solve now with science. It's there. So that point of care you're talking about, let's get there like quick. And whoever knows the people at the FDA, get those jammed through so they're finished. There's 19 companies right now in the United States trying to get point of care saliva tests done. 19. And they're all stuck in the FDA. So help.
We do need a salesperson like Bob. And
Who's with the FDA here? Anybody?
if you're gonna make only 30,000 patients of the CF to get a nationwide recognition, if we could, launching a national oral health initiative or whatever, make everybody to be aware of the importance of oral health, maybe the situation would be different.
Yeah, and I think one of the biggest problems that we have in our profession is we don't have a defined definition of what is the minimum standard of oral health. Okay, in cancer treatment, the minimum standard for cancer treatment is no cancer cells. In dentistry, so if you look at the Medicare system, we expanded into medical necessity. And in the Medicare system, it's removal of infected teeth. There's nothing in there about rebuilding. So if you have oral cancer, you get all those teeth removed prior to radiation therapy, but you get nothing rebuilt through the Medicare system. Okay, because there's no defined benefit. That needs to be defined, and that's going to be a huge controversial topic within the profession because everybody's got their own take on it. So I'm the first one talking about it, so I'll give you mine. Okay, mine is removal of any kind of infection. Okay, whether that's tooth infection or gum infection, the ability to chew. Okay, doesn't mean you have to have all of your teeth, but you have to have enough that you can actually have a chewing mastication because that's what really teeth do best. Okay, and then you have to be able to face the world with dignity. Okay, because in this country right now, if you're missing a front tooth, okay, you're perceived very differently than if you're not missing a front tooth. And we have a crisis in well-being right now. And people, if they don't have a smile that they can at least face the world, that's going to accelerate it is accelerating the well-being issues. And in this country right now, is healthcare a privilege or is it a right? Healthcare is a right. Oral health care is a privilege. If you have money, you can access dentistry. If you don't, you can't. That's the bottom line. If we are going to be essential, that has to be included. And this, we have so much infighting within the profession about what does this mean, you know? And so I gave that example of the hip replacement. Okay, is that medically necessary? Some people say yes, some people say no. Is a front tooth medically necessary? Some people say yes, some people say no. We have to come to we have to start having these discussions or we will not move forward because the insurance company says this is what we cover because this is what we cover. The government says this is what we cover because this is what we cover. Dentists, every dentist has a different definition of how to rebuild this case or how to treat this case because it's all over the place. Crazy. So I'm going to shift gears again into, there's what's the guy's name? Rogers' law of diffusion with innovation. Okay, there's a lot of studies that show when a new technology is integrated into the system, there's a group that are called the innovators, about 2.5%. Then the early adopters, about 3.5%. Then the early majority, the late majority, so it's a big bell curve, it starts building in the early majority, late majority, and then the laggards. And Simon Sinek talks about the laggards. They would still be using rotary phones if it was still available. Okay, those are the last to go in. But where are we on the spectrum right now? I think we're in the innovation, the 2.5%, and some early adopters. And until we get into that early majority where we hit that tipping point, it's about 30% are using this new technology, that's when it'll go. So in the meantime, we've been talking about this, Steve talks about 2015. I've been trying to do this for 30 years in my entire practice life, connecting the mouth to the body. And I talk to my patients about it. My patients love that I talk about it, but then they see their benefit and what's covered. And you see that look of disappointment on their face every single time. Why do I even pay for it? And I tell them, go back to your HR at your company.
Yeah, don't come to me.
No, because it's not your fault. What happens is what people don't know. It's not the insurance company's fault. It's the HR, makes a deal what they want to pay, what they want to invest in their employees, and that plan is defined by the employer and the insurance company, right? Okay, it's not the insurance company's denying it because it's not necessary. They're denying it because it's not in the plan most of the time.
Or what the employer is willing to pay for, right? I mean, I
Right.
think this perception of, and I agree with Steve, I mean, it's been fixed at $1,500 to $1,800 level. We've had situations where we've offered up programs for unlimited yearly maxes. And folks don't buy it because the employers are going, okay, I want this product. And we say, okay, if you want that product, this is the cost level. And they go, no, just kidding. I want the 180.50.
Yeah.
And if the broker quotes me a premium rate that's $1 more per month, I will drop you like a hot sack of potatoes. And that's not even a good analogy. And I'll drop you and we'll move off to somebody else can offer it to me cheaper. And in the context now is, like I said, with the rising healthcare premium dollars, that decision-making process becomes even more pointed because there is not the perception right now of the value for the increased dollars that the employers have to pay to cover their employees. And that's shame on us, right? Because we need to share that importance. What I think needs to happen, and it went, and David talked a little bit about it relative to how do we repurpose these premium dollars more up, I call it more upstream, right? How do we push the premium dollars away from class 3 services up to class 1 and class 2, right? Because that allows us to get more upstream of the disease state. Theoretically, if you can control it earlier, you're less likely to have implants and, endo and everything else. So there's that piece of it. The other of it, and I think now we're in a confluence of technology and understanding because of the research, that our ability to drive these services, what were traditionally been done on the physician side into the dental practices, is important to us, right? Because we want to obviously stop things earlier. The other element to it, we haven't talked much about it, which is the huge issue we have in dentistry right now with hygienists. In Pennsylvania alone, there's a shortage of 9,000 hygienists in just Pennsylvania. So docs are spending a lot more for salaries and benefits to keep and retain. And Steve, you live that every moment, right? I mean, keeping hygienists. And so our ability to take some of these services, which have traditionally been just in the medical environment and doing capillary draws instead of venous draws, having mid-level providers, having hygienists perform these services to generate revenue in the prophy department, in the hygiene departments becomes that much more important, right? Because you have to pay these folks that much more to retain them and find them. So I think it kind of all works together. We have this kind of confluence of technology, markets dynamics, macroeconomic trends that are pushing, I think, the industry in a way that really meets what we're trying to accomplish.
Well, can I go? I I feel like it's the same conversation here. We got to be real. If practice, if any of you are just doing prophies and your hygienist doing prophies, you're losing money, right? They have to do some level of SRPs in order to pay the bills, right?
I would just
For
like to
sure.
say, it's got to be ethically driven.
Correct.
Do SRP because you need more.
No, right.
Right, okay.
But there's got to be a mix
Indicate-
of patients
patient
that need SRP.
Right.
Well, 70% of seniors,
Exactly.
50% of Americans have periodontal. Odds are in our favor, right? The brokers play a gigantic role. Huge. And if they're not prepared properly to have the discussion about why they should invest a little bit more in the oral health benefit to offset the medical costs and bring down their medical costs, we're not doing our job, to your point. So hats off to Delta Dental of Arizona, okay? Delta Dental of Arizona is paying us to do A1C testing on all their patients and report back the data, and we're tracking that data. His thesis is that we're going to prove the decreased A1C. That's all proven in the research and science, so it's happening. And he will be able to sell that to employers, that we're reducing their ED visits and hospitalizations. So that plan will sell better than the other plans. It's an example of one of the leaders out there trying something, rather than relying on that 180/50 and doing a different test. And it's just a, whatever, finger prick test, whatever. Simple. Dentists can do
And do
that.
dentists do it or hygienists do it?
Yeah.
Assistants do it?
Dentists,
Right?
I think the dentist and hygienist, I don't know,
Uh-huh.
dentists and hygienists, I don't know.
Yeah.
But there are examples
Mhm.
of certain leaders out there in our space trying some stuff
Mhm.
to change the paradigm of dental benefits. So I want to encourage, we got a couple leaders in here that control, I think between the two in here, probably have 40 million lives, is my guess. It's like, let's do something.
Yeah. They're on
Let's
the
go for
innovator
it.
side of the curve.
Well, the two in the room aren't doing anything yet.
Yeah.
But
Well,
the other,
to be fair to Ed,
we're trying.
to be fair to Ed,
I want to give him
Throw a flag.
props. We're trying. We're trying.
we're
not there
actually
yet.
developing some program and
But we're not implementing it yet.
yes.
Okay.
Right. We're working.
And we're actually talking to David
working
too
on it.
about it.
Yeah,
I
yeah.
think we all, to your point, Steve, we all agree it's never going to be fast enough. But we
No.
are, I think, really at that.
We're
tipping
getting
point where,
serious.
like you and I, and all of us go around to all these conferences. We've all been doing this for
It's time.
years. It's like enough already. Come on, let's.
David.
Yeah, and I'd say this is illuminating the fact that this is 10,000 hands pushing the stone up the mountain here, right? And it's really a collective effort. So we're coming at it a little bit different way. We want to try a number of things, but one way we're working at this is working with CareQuest in partnership, trying to say, all right, let's leave the reimbursement to the side. Can we come up with a cash pay system where patients are willing to pay for an elevated hygiene exam? And as part of that, they're cash paying a relatively low amount. But within the temporal limitations of an existing hygiene visit, we can provide an elevated health screening, providing them with meaningful information that the patients can then go and use to help close those care gaps, plus helping to close the care gaps. From the profession side, the key indicator for us, and it may seem like a very small step, but I think it's important, is educating the dental team that you can do this. You actually can be a primary. You can have that discussion there. It doesn't have to lengthen the hygiene exam. It's not going to mess with your economics. And where we're starting, again, just because looking for the shortest putt here, is we're starting with simple, easy to use, readily accessible, relatively inexpensive point of care tests that are already used. They're capillary blood draw, so finger prick, that are already used on the medical side because we have our feet in both sides of that. If we can show that we can easily train teams, and I'm saying we, Shine, because we're going to go in with the products. Often we have these discussions. We can show that we can train teams pretty easily to incorporate some sort of capillary blood testing. That's not the end state, but at least starts getting people's minds shifted, and it creates some muscle memory and some best practices. Then you can layer on top of that other tests. And all of this inexorably can lead very easily to incorporating salivary diagnostics. So again, I bring this back to the point, I don't think there's one silver bullet. If there was, it would have been done. We have to try a lot of different things, a collective effort to build that consensus. But, I like the quote that you talked about in terms of technological adoption. I also really love the Malcolm Gladwell tipping point thing, right?
Right.
It kind of backs up to a certain point, and then at some point you go over the threshold there. I think us collectively are helping to build to
Yeah,
that.
he's referencing the same study. And when we get to that about 30% in that early majority, that's when the tipping point will happen and it will flow through. But in the meantime, we just keep kind of pushing in the innovator and early adoption side where we're doing. And it seems like we're going against a wall, but eventually we will break through that wall if we keep pushing, and we got to keep pushing. So I'm going to shift gears a little bit here. My friend Maria Filipova, I don't know if she's in the room or not, she's out there, but Dr. Rich Rosado and myself had a dinner with her, and we were talking about these things, and she asked us this question, what's the first domino? What's the first domino that will fall to get us up to that early majority? And I'd love to hear what you think about that.
Yeah, I think we have to be able to prove it in both settings, right? Like at CareQuest, the way we have been approaching this has sort of been threefold. It's bringing, dental initiatives into medical settings, medical initiatives into dental settings, and how do we also provide those enabling structures? I think Steve and David gave great examples of what we're seeing as sort of these immediate actions that can be taken right now to help prove that case. On the flip side of the sort of innovator discussion, we've seen numerous examples of a lot of these programs that have been stood up, and after a year, they are shut down due to resourcing, due to reprioritization. And you can't let resourcing get in the way of trying to, build innovation. And so that's where, for us, if we can be an enabler of more of that innovation, to be able to tell more stories like this, to be able to help make the quality and the cost, story stronger, I think for us, that's how we are approaching it in terms of trying to help that first domino fall.
Great. Ed?
I think domino's already fallen. I mean, I think Steve's certainly a perfect example of, I would say, there's a spectrum of this integration, right? And Steve's team has done probably the gold standard of cohabitation of the physicians and dentists in one location. I think there's going to be now, you're going to start to see a myriad of things and programs and products that are going to come out that may not be perfect, but they're along that spectrum. And let's not get too carried away. If we think about what are we trying to do here? Are you going to the dentist or you're not? Do you have periodontal disease or not? If you have periodontal disease, are you getting it treated? Do you have caries or not? If you have caries, get it treated. I mean, let's not overanalyze this in the first steps. Could we have a lot more information? Could we get fully integrated with health information? You betcha. But the harsh reality is it's so siloed right now. We can't even get folks to agree to a common form to fill out, right? I mean, we're a long way away from getting that full integration. But I don't think that precludes us from making attempts, even though it may not be perfect, to get us better than where we are right now. And then so from my perspective, I think we've reached a tipping point. Steve's a perfect example. He's already taken action on it. David is too. We're all working on it. And I think within the next year, I'm pretty confident that by this time next year, you're going to see people that have addressed this, and we're going to see more things we could talk about next year for sure.
From your mouth to God's ear.
Yeah.
Yeah, I think you're right. From a kind of tech standpoint, I think it's saliva. I think that's going to be a major tipping point. The domino that'll change our world, and you guys may hate me after this, but no more dental plans. We get one health plan.
Yeah.
Serious.
Yeah.
No more dental plans. We get one health plan. Merge with your medical, Highmark and United Concordia. Every patient gets one. That will change the mindset of every patient walking in. We have to change the mindset. Get rid of dental plans, get rid of the CDT code. Sorry, you guys own it. But one health plan for all of us.
That's not the first domino. That's just the last piece of domino.
No, that's what that'll change our worlds.
Yeah, I know. Well, first of all, I think the first domino that what we're doing in this room, all the decision maker about oral health is here. And we're very honored to play in this convening role for people to talk to each other. That is the first step. And try being the friend with all sides. And I actually certainly, my experience is everybody want improvement. Everybody talking about the same thing. And I certainly see science and data is the universal language. And what really seems to me right now is conceptually everybody on the same page. The first domino to me is somebody going to create one little payer system actually can make money. Then everybody else will be jumping on the same model.
Right. As I mentioned in my presentation about how we jumped into airway management because we found a way to get paid for it. So, David.
Yeah, I'm going to kind of me too. And I think that was the pilot that I was describing. I mean, our thesis is that if we can show people how they can implement something where they're not losing money and making a little bit of money, that will help usher in payers actually going and reimbursing, and then it all becomes accretive there. But I'd go back to my point here. We can't do this alone. We need the public alongside here. So you want to see a really important, maybe not the first, really important domino. When people start really talking about this, not as sick care, but about screening, prevention, and wellness, and then hopefully, and I'm not trying to upset our medical customers, think about the dental visit as the gateway to healthcare. That's where you're going year after year, as long as you don't have an acute or chronic condition.
Yeah, patients come to see us in a preventative mindset. They don't go to their physicians in that mindset anymore. Very rare do they do that. Women are better than men because you're trained with your gynecological exams, but men, we don't go unless our arms are broken. And then, they screen you for diabetes because your arm's broken. That's the only way we go to the doctor. With this volatile political environment that we're in, healthcare is being challenged, science is being challenged, but the greatest opportunity is dentistry. The conversation of dentistry has risen to the level of the President of the United States. That's never happened before. We don't like how it happened, okay? But we've got this great opportunity because when it comes time to fix the problems that we may be creating right now, they're going to come to us and we're going to be able to solve those problems, okay? Our friend Bobby talked about patient-centered care, the patient in the middle of all of this, okay? I don't care what kind of benefits you have. Most people don't like coming to see us. They don't say, wow, today's my dental visit. I'm going to get drilled on and shot and it's going to cost me a lot of money and it's going to hurt for days. And, that's the reality of dentistry. And, if we can find technology to help, create that patient experience better, that's, in my opinion, the biggest driver of healthcare. We heard it, Maria talked about it when she said the patient was at the physician and saw, this was in one of your clinics, and saw, why is there a dental chair there? Okay. And, patients, if they can go and get their medical stuff done and their dental stuff done in one sitting, imagine if they had 4 kids and they get all their vaccines on the medical side and then they get their prophies and exams on the dental side. Okay, imagine the convenience factor for the patient. We talk about teledentistry as being a driver for those that can't access care. But I can tell you the ones that can access care will try to do teledentistry too. We saw that with Smile Direct Club. Okay. Because they're finding easier ways to access dentistry. They know it's kind of important, but they don't want to go. We have to accept that. And I think, what we're going to be doing at the American Dental Association under Dr. Rosado next year is, the Oral Health 2050 project. What will the delivery of oral health care look like 25 years from now? And if you think about year 2000, to today, dentistry has changed immensely. Technology that was at the beginning, like I talked about with radiographs, digital charts are new in those 25 years. Radiographs, milling, printing, all of these things are there. in 25 years? What's going to look like in the next 25 years? And I think we'd love to partner with all of you. And we want all of you to go back to your entities and start imagining what dentistry will be like, what oral healthcare delivery will look like 25 years from now. Because if we can imagine it, we can drive it. This is where I think medicine left it on the table and let the legislators and regulators define it for them.
I think you have it exactly right. Dentists are uniquely set up to be the conduit for every patient's primary care. Because those that do go to the dentist go way more often, like you said, than a primary care provider. In our network, 9 million patients, average, I think 2.7 visits, 2.7 times to talk to them about their oral health and the connection to all these chronic inflammatory diseases that we so fear, right? And what's the most chronic inflammatory disease in the world, Maria? Periodontal disease. And we get to talk to them about that, right? And it's like, we got to go after it big time. Everything you said in your opening. We need more dentists talking like that every single day.
Well, I'm hoping that we can, shift the conversation.
Yeah.
Because it's a definite paradigm shift. Next week, this is really exciting for me, and I think it's really exciting for the profession. At the health conference in Las Vegas, I'm going to be on a panel with the president. I'm the president of the ADA, the president of the American Medical Association, the president of the American Nurses Association. For the first time ever, the three of us are in a room together. It's never happened. Kathy O'Laughlin, is she in the room? Does that ever happen before? Okay, this is like the conversations are starting to happen. And, and we're getting closer to that tipping point, but we have to keep pushing. We have to keep pushing as if our lives depend upon it and the lives of our patients do. So we are 5, 4, 3, 2, 1. That's it. Thank you very much, everybody. Thank you to our panel.